The following podcast is part of a certified educational activity titled Raising Frontline Expectations in Diffuse Large B-Cell Lymphoma, Principles for Refining Upfront Treatment and Addressing Unmet Needs with Modern Antibody-Based Combinations. Access the entire activity and complete the post-test at peerview.com/VFP860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Greg Nowakowski from Mayo Clinic, Rochester. Welcome to this micro-learning program on newer antibody-based combinations for the first-line management of diffuse large B-cell lymphoma. Today, we'll learn that evidence and guidelines support the continued integration of newer combinations with antibody-drug conjugates as a first-line treatment for diffuse large B-cell lymphoma. Several proven dosing and safety management strategies can help ensure the tolerability and ADC-based regimens while maintaining efficacy. Using ADC therapy in the frontline setting has implications for what is chosen later on, including the bridging therapy for prior CAR T cells, and that new strategies combining ADCs and bispecifics, including with each other, are being explored as a second and even first-line management of diffuse large B-cell lymphoma. We'll address those topics with a series of educational modules on DLBCL management designed to explore the rationale for newer combinations on the first-line setting and the clinical experience with modern immunotherapy regimens. Let's begin. You just seen a question on patient outcomes during era of R-CHOP. Let's find out more about this topic and some of the major prognostic factors in diffuse large B-cell lymphoma. This slide illustrates well current situation with the frontline therapy. As you can see here, approximately 40% of the patients will relapse after frontline therapy, and those relapses typically happens early on within the first year. What you can also see here is that the shape of the curves from time to progression, progression-free survival closely resembles the curves of overall survival, which means that unfortunately, majority of the patients after relapse will succumb to the disease. Therefore, there is a huge interest in improving initial outcomes of therapy for patients with large cell lymphoma. If we look at the patients with relapse and refractory disease, and this is the data from SCHOLAR study, you can see that the patients with primary refractory disease, which were a significant proportion of the patients in SCHOLAR 1 study, have very poor outcome with very poor event-free survival and median overall survival approximately 7 months. So patients with refractory disease to R-CHOP do poorly, and this highlights this need for development of novel therapies in this setting. And we also know from many studies now that with subsequent lines of therapies, the patient outcome is decreasing. Therefore, the major focus is really on preventing relapse throughout those lines of therapy. IPI, International Prognostic Index, has been used for many years to predict the outcome of patients treated with frontline chemotherapy and chemoimmunotherapy. Interestingly, this system was developed in 1993, so quite a long time ago, but it validated very well in the modern chemoimmunotherapy era and is essentially able to divide patients into the prognostic groups based on a simple clinical predictors, including age, LDH, disease stage, ECOG performance status, and number of external sites. And in general, we divide patients in low, intermediate, high intermediate, and high risk groups. There are some refinements of this system as well. Here you can see a data from Mayo Clinic, which shows that some patients with low IPI, 1 to 2, still have a high-risk disease, and they track along the IPI 3 if they have a bulk of the disease defined as more than 7 centimeters or elevated LDH. And perhaps this clinical stratification shows some of the limitations of IPI. Colleague of mine, Dr. Bock, performed this study where she looked at patients with truly primary refractory disease, so patients who progress through frontline immunochemotherapy. And she looked at over 2,700 patients to identify a number of patients, slightly over 140, with this truly progressive disease. And what's interesting about it is that almost half of those patients have low IPI at the time of diagnosis, of IPI scores 0 to 2. So by clinical prognostic factors. They were defined as high risk, yet they had a primary refractory disease. And we now recognize it quite well because there are factors associated with the disease, which are actually primary drivers. So tumor bulk is one of them, high LDH, as we already mentioned, uh, double hit or triple hit lymphoma, or double expressors of MEK and BCL2 is associated with the worst outcome, presence of extranodal disease, and disease stage and burden all are factors in development of primary refractory disease. Now, perhaps one of the best classified in this setting are the patients with so-called double hit lymphoma, which we typically identify as fluorescent in situ hybridization. So patients who have MYC and IGH and BCL2 and IGH translocation do worse with a 3-year overall survival estimated to between 30 to 40%. We also recognize that patients with ABC or non-GCP subtype of diffuse large B-cell lymphoma, as defined by immunohistochemistry or gene expression profile respectively, have worse outcome with overall survival about 30 to 40%. And we also recognize that those subtypes are also not uniform. There's heterogeneity between the patients with ABC subtype and GCB subtype, and there are newer classifications which are molecularly driven by specific mutations. And those classifications are in progress and likely will drive the progress of identification of patients at risk for relapse in the future. Mostly, they still remain research-based. Most of the centers have access to immunohistochemistry for cell of origin and FISH for double and triple hit lymphoma. But the access, real-time access to these molecular classifications based on molecular drivers is still primarily a research tool. Let's explore current practice guidelines in more detail and take a look at evidence that has informed the addition of polatuzumab vedotin to R-CHP chemoimmunotherapy. This is a current NCI guidelines, and what it highlights is that there's recommendation to introduce polatuzumab vedotin R-CHP combination in patients with advanced stage disease with IPI 2 and above, and also in patients with limited stage disease, based on the study called pola-R-GemOx, which we'll overview in a minute. In patients who relapse following initial chemoimmunotherapy, if the relapse happen in less than 12 months, so they are considered to have primary refractory disease based on randomized studies comparing high-dose chemotherapy and transplant versus CAR T-cell therapy. CAR T-cell therapy became the preferred option. And this is and its use is associated with not only better progression-free and event-free survival, but also overall survival. So patients who are candidates for CAR T-cell therapy should be considered for those therapy. Patients who are not eligible for CAR T-cell therapy with early relapse should be considered for a number of novel therapies in this space, including bispecific antibodies with epcoritamab and glofitamab. Polatuzumab vedotin is also used in this setting in combination with bendamustine and rituximab, and also in combination with bispecific antibody mosunetuzumab. Tafasitamab and lenalidomide is also used in this setting. However, typically excluding patients with primary refractory disease, as those patients were not originally included in L-MIND's study. The patients who relapse after chemoimmunotherapy, particularly with every relapse, have frequently significant bulk of the disease, and this necessitates occasionally bridging therapy to stabilize the disease prior to CAR T-cells can be used. And here, the options are somewhat similar for the patients who are not immediately proceeding to CAR T-cells, with polatuzumab vedotin and rituximab historically used quite extensively in this setting, occasionally with bendamustine, sometimes with the omission of bendamustine to avoid lymphodepletion. Patients who relapse more than 12 months after diagnosis, they tend to be quite chemosensitive. So preferred regimens in those patients would be still intensive platinum-based chemotherapy plus rituximab. And if their response is seen, they typically proceed to high-dose chemotherapy and autologous stem cell transplantation with quite favorable outcomes. So it's important to remember that. Now, patients who are not the candidates for high-dose chemotherapy, they still may be candidates for CAR T-cell therapy. and a number of novel approaches with bispecific antibodies and antibody-drug conjugates are listed here. So let's take a closer look at the pola-R-X study. This was a very large randomized study in a frontline treatment of patients with diffuse large B-cell lymphoma. These were adult patients, age 18 to 80, with IPI 2 and 5. And those patients were randomized 1-to-1 to polatuzumab R-CHP therapy versus R-CHOP. So this was really a replacement of vincristine study with polatuzumab vedotin. The reason for replacement of vincristine rather than addition to vincristine is that vedotin is also a mitotic spindle toxin and can induce neuropathy. So to avoid this overlapping toxicity, vincristine was substituted with this more modern antibody-drug conjugate. Patients were treated for a total of 6 cycles of therapy, after which there were additional 2 infusions of rituximab. That's because the practice or the duration of rituximab treatment in the world varies quite a bit. This was a global study, and some centers do use those additional infusions of rituximab for cycle 7 and 8. The primary endpoint of this study was typical for those phase 3 studies in the frontline setting, which is progression-free survival, and there was a number of secondary endpoints. The initial publication of this study, which was published in New England Journal of Medicine, showed that use of polatuzumab vedotin was associated with significant improvement of progression-free survival. At 2 years, it was 76.7 versus 70.2% in R-CHOP arm. Now, the relative risk reduction was about 6.5%. I'm sorry, absolute risk reduction was 6.5%. But if you look at the relative risk reduction, it was actually 27%. So 27% of patients had a reduced risk of death or progression with your use of polatuzumab vedotin, which we felt was a major breakthrough and significant improvement over what was seen previously with R-CHOP. And you can see it here graphically. You can see that there's a separation of those progression-free survival curves. And what's important is with this update, which was presented recently at the ASH meeting by Dr. Salas and colleagues, you can see that this separation remains over time. So not only that this benefit was seen early on in the study at 2 years, but it's sustainable over 5 years of reporting now. But what we had seen in this study, there was a clear reduction in a number of subsequent use of salvage therapies. And it makes sense because the progression-free survival has improved, so less patients require subsequent systemic therapy, platinum-based therapy, salvage with transplant or CAR T cells, or salvage with radiation therapy. You just see the question about the patients with newly diagnosed diffuse large B-cell lymphoma. Let's explore this case in more detail and discuss management options. So this is a 68-year-old man with newly diagnosed diffuse large B-cell lymphoma, stage 3, an IPI score of 3, with no significant cardiac comorbidities. And testing confirms the ABC subtype of diffuse large B-cell lymphoma. So let's first try to focus on what will be expected prognosis of these patients, and then what will be the therapy options. We mentioned that ABC subtype of diffuse large B-cell lymphoma is associated with worse outcome when treated with chemoimmunotherapy. The estimated 5-year overall survival of those patients is somewhere between 30 to 40%, versus about 60% for all comers. Polatuzumab vedotin combined with R-CHP has shown particular benefit in patients with ABC or non-GCB subtype of diffuse large B-cell lymphoma, which resulted in the current recommendations in the guidelines. Other regimens, which are not anthracycline contained, could be more useful for frail patients, but I think based on this patient and lack of other comorbidities, this patient would be indeed a candidate for this regimen. Here you can see NCCN recommendations for use of polatuzumab vedotin in the frontline therapy of patients with large cell lymphoma. And you can see this as a preferred regimen for patients with IPI 2 and above, for both patients with limited and advanced stage disease. Now, what was interesting in the subgroup analysis of pola-R-X study that patients with ABC subtype appear to derive particular benefit from addition of platuzumab vedotin. And you can see here on this slide that there was quite a dramatic difference in a progression-free survival in this setting. This has resulted in some of the groups, national groups, recommending the use of platuzumab vedotin specifically for ABC patients. This slide was shared by Dr. David Scott from British Columbia Cancer, and this is their new approach in Canada. Now, to be able to use this approach in real time, you need to have this gene expression profiling performed to be able truly to identify those ABC patients which appear to be at best specific benefit of platuzumab, additional platuzumab vedotin. For the most centers who do not have access to this technology in the clinical practice, platuzumab vedotin is used across the molecular subtypes of R-cell lymphoma. And just recently at Lugano meeting, a group of Dr. Ship presented the data that with their classification using the molecularly defined clusters, there are specific molecular clusters as well, like C5, which has a particularly pronounced benefit of additional platuzumab vedotin in this setting. Again, those molecular clusters are very interesting scientifically, and we would like to understand why polatuzumab has specific activity in those clusters. Currently, they're not really available in real time in the practice, so we tend to treat essentially all patients with newly diagnosed diffuse large B-cell lymphoma with additional platuzumab vedotin, unless you have access to those classifiers. Although the overall survival difference in the study was not evident, primarily due to use of salvage therapies, which are improving, you can actually see that in analysis of POLARIX study at the 5 years, there is an evidence of reduction in a number of deaths due to lymphoma. So that's extremely encouraging for the sustained benefit of this regimen. And importantly, during the long-term follow-up, there was no additional toxicities uncovered. So this regimen was quite comparable with R-CHOP at the time of initial study publication, and with additional follow-up, there is really no new toxicities. Let's review a case and take a look at some important dosing and safety information with newer antibody options in diffuse large B-cell lymphoma. So this is a case of 74-year-old woman with newly diagnosed diffuse large B-cell lymphoma, IPI-2. The patient is preparing to receive pola-R-CHP. But what are some of the safety considerations when we are planning this treatment, and some of the strategies to help mitigate infusion reactions in peripheral neuropathy? Well, with R-CHP regimens, vigilance for neuropathy, myelosuppression, and other AEs is definitely warranted. For infusion reactions, premedication is typically done with antihistamine and antipyretic, plus monitoring during infusion. Steroid premedication typically is not required with polatuzumab vedotin, but is frequently recommended with other antibody-drug conjugates. If we look at the adverse events associated with this therapy in the frontline setting, you can see they are primarily hematological. So neutropenia grade 3 and above is actually quite common, affecting 38% of the patients. Peripheral neuropathy, all grades, affects about 13% of the patients. And additional toxicities seen is diarrhea and fatigue. What I would like to draw your attention to, though, is febrile neutropenia, which is affecting approximately 8% of the patients. So despite about 38% of the patients having this neutropenia, febrile neutropenia is actually quite uncommon. And this is a reflection of the fact that this neutropenia is typically of the short duration and not associated with the infections. You can also see that infusion-related reactions are quite uncommon as well, up to 8%. And upgraded POLARIX analysis shows no new safety signals over time. That's important because we always worry about late toxicity in those studies, which are designed to cure our patients. And this extended analysis really showed no evidence of new sustained toxicities. The premedication with antihistamine antipyretic to reduce the risk of infusion-related reactions is typically used with platuzumab vedotin, and the R-CHOP21 is given at the standard dose with platuzumab vedotin added at 1.8 milligrams per kilogram on day 1 of each 21-day cycles for 6 cycles, as we discussed. This slide overviews the guidance of neuropathy. I think it's very important to monitor our patients for neuropathy because it's one of those conditions which gets worse before it gets better. So with each cycle of therapy, we need to investigate for development of neuropathy. And you can see that in general for grade 1 neuropathy that we can continue the therapy. For grade 2 sensory neuropathy, we wait usually for resolution to grade 1 prior to next dose. If it persists at the next scheduled dose, we reduce by 1 dose level. For day grade 3, we typically would withhold until grade 2 for sensory neuropathy, and grade 4 obviously would permanently discontinue the drug as the grade 4 is tend to be quite severe clinically. In terms of the motor neuropathy, grade 2 or 3 results in withholding at the grade 1 or lower, and reduction to grade 1 level because peripheral motor neuropathy is more concerning during the therapy. And obviously, in a grade 4 will result in a permanent discontinuation of the drug. Other selected adverse events, so myelosuppression. So we typically would monitor CBC just like we do with any chemoimmunotherapy. Growth factor support here is extremely helpful in maintaining dose intensity and should be used in those patients. As with any other chemoimmunotherapy as well, we monitor patients for signs of opportunistic infections. The practice guidelines vary by site and what supportive care we use in this regard, but definitely we are very mindful here in all our lymphoma patients. Risk of PML is something which we monitor with cognitive and behavioral changes. Fortunately, it's a quite rare complication, particularly in a frontline setting. And finally, hepatotoxicity is monitored with each cycle of therapy. What are the selected safety considerations with some of the other therapies with antibody-drug conjugates? So loncastuximab is another antibody-drug conjugate, which is frequently used in a relapsed refractory setting. It is actually a useful agent either for the early on in the relapse and even in the patients who are relapsing post-CAR T-cell therapy. This drug is given every 3 weeks at the dose and schedule as seen here. And for those patients treated with loncastuximab vedotin, monitoring for cytopenias is very important. The specific toxicity of this drug is elevation of liver function tests, particularly GGT. So that's something which has to be monitored with application. And also, some of the patients can develop peripheral edema and effusions. We poorly understand the mechanism of it, but generally it tends to improve with steroids and diuretics. So dose modifications may be needed for this as well. Bispecific antibodies like glofitamab and epcoritamab have quite different safety profile. You can see here the dosing schedule of glofitamab, which starts from pre-dosing with obituzumab to reduce the risk of cytokine release syndrome, and subsequently dose escalations of glofitamab. The major risk with bispecific antibodies, including glofitamab, is development of cytokine release syndrome. And this typically happens during this step-up doses. For glofitamab, it tends to occur on day 15. So that's something which really requires very close monitoring and sometimes admission of the patient to the hospital based on local practice. Similarly, with epcoritamab, there is a step-up dose. Here, there is no preloading with obinutuzumab or any other CD20 antibody, but the step-up dosing is a little bit different. And predictably, cytokine release syndrome tends to happen on day 15, step-up dosing. Again, those patients require quite close monitoring and frequent hospitalization to monitor for cytokine release syndrome. If we look at category of bispecific antibodies, both used in relapsed refractory diffuse large B-cell lymphoma with epcoritamab and glofitamab. Major toxicities being cytokine release syndrome. That the hematological toxicities are not as common, but we do see neutropenia with both of those agents. And associated with this, we may actually see infections. And those infections may happen in a setting either of neutropenia or occasionally due to prolonged exposure due to a B-cell depletion. So being very mindful and monitoring patients for infection and using infectious prophylaxis or bispecific antibodies, particularly if used in the long term, is very important. Overall, if we think about mitigation of some of the T-cell engagers, CRS in infections, the step-up doses definitely helps with the close monitoring of patients. In addition to hospitalization, many centers are now moving towards using remote devices to monitor those patients, wearable devices. And those, if those occur, they're typically managed with antipyretics, corticosteroids, and tocilizumab, so anti-IL-6 therapy. Infections do require careful monitoring for latent infections, particularly patients with prolonged exposure. And in patients who have recurrent bacterial infections and have hypogammaglobulinemia, IVIG replacement is frequently used. Again, neutropenia may happen with bispecific antibodies. It's typically maturation defect of neutrophils, and they tend to be quite responsive to growth factor support. So we recommend using growth factor support in this setting to maintain dose intensity and avoid those complications. Now, let's turn to a case where evidence supports the use of a newer combination strategy with bispecific antibody, but also explore some of the next steps with ADCs and bispecific therapies in diffuse large B-cell lymphoma. So this is a 72-year-old patient with large cell lymphoma, which relapsed 3 months after pola-R-GemOx R-CHP therapy. So this is an early relapse of large cell lymphoma. The patient is now presents with abdominal pain. PET scan shows large abdominal mass, and the patient has also ascites, proliffusions, and intrathoracic adenopathy. Now, this patient with early relapse would be a potential candidate for CAR T-cell therapy. The problem is he does have those symptoms associated with the bulk of the disease. So what would be the best next steps on bridging this patient to CAR T-cell therapy? And here we have some options. Rechallenging with pola-R-GemOx, since the patient already progressed early on after pola-R-GemOx, would probably be suboptimal. Pola-R-GemOx vedotin in combination with rituximab, or sometimes rituximab and bendamustine, has been used extensively by many centers, including us, as a bridging strategy to CAR T cells. But with the more and more common use of pola-R-GemOx R-CHP up front in the patients with early relapse or disease which is primary refractory to pola-R-CHP, this rechallenge would be suboptimal. A traditional chemotherapy or chemoimmunotherapy like R-GemOx or R-ICE and others are relatively ineffective in this patient population because the response rate to salvage therapy in the second line patients who are truly refractory to first-line immunochemotherapy is actually quite low. What appears to be a good option for those patients is a combination of chemoimmunotherapy with bispecific antibody like glofitamab and R-GemOx. And this was evident from the STARGLO study. So this is just again to remind you about the landscape. So this patient would fall in this category of early relapsed, which would be eligible for CAR T-cell therapy. And if you look at the STARGLO study, this is a phase 3 trial, which is looking at addition of glofitamab to GemOx and comparing it to a GemOx regimen alone. The study was designed as a 2-to-1 randomization to facilitate accrual to the experimental therapy arm. The patients had to have relapsed refractory diffuse large B-cell lymphoma with at least 1 line of prior therapy, and patients with 1 line of prior therapy had to be transplant ineligible. So this study was capturing those patients who were traditionally transplant ineligible, failing R-CHOP, or with failing salvage therapy. The study enrolled 274 patients. And what was interesting about this study, the primary endpoint of the study was an overall survival, with the key secondary endpoints looking at the tumor control. You can also see the study schema here. So after initial therapy with chemoimmunotherapy through cycles 1 to 8, patients continued on glofitamab through the cycles 9 to 12. The study showed quite a dramatic difference in overall survival, where addition of the glofitamab to GemOx resulted in a significantly improved overall survival. Now, in addition to the significant improvement in overall survival, we can see that the tumor control was consistent with those results and much improved with addition of bispecific antibody. So overall response rate was approaching 70% with the addition of glofitamab to GemOx, up from about 40%. And the CR rate was actually approaching 60%, up from about 25% with chemoimmunotherapy only. And that's extremely important because if we think about this regimen as a potential bridging strategy in the second line and other uses, this high response rate and high CR rate is extremely meaningful because it lets us buy the time to look into the cellular therapies or other consolidated therapies later on. And antibody-drug conjugates can also be combined with chemoimmunotherapy. And here are results from the pola-R-GO study, which was presented at a recent EHA meeting, showing that addition of polatuzumab vedotin to R-GemOx was also associated with improved overall survival compared with R-GemOx alone in the patients with relapsed refractory diffuse large B-cell lymphoma. So it's an important principle that this antibody-drug conjugates can be actually combined with chemoimmunotherapy and indeed are improving results in this setting. And of course, antibody-drug conjugates can be also considered for combination of bispecific antibodies. And here we have example the LOTIS-7 study, which is looking at the combination of loncastuximab dacitorin with glofitamab in patients with second-line and beyond relapsed refractory large cell lymphoma. And in the study, we see potential synergistic effects resulting in a very high overall response rate, over exceeding 90%. But look at those CR rates; they're also approaching 90%. So very high response rate for combination of antibody-drug conjugate with bispecific antibody, and really deep responses resulting in a CR rate approaching 90%. The study has relatively short follow-up, but early on, the duration of response appeared to be quite promising. In the ongoing landscape of therapy, we have now a number of frontline studies who actually are using this principle of combination of bispecific antibody and antibody-drug conjugate. And one of those studies is a SkyGlow study, which is looking at the combination of glofitamab plus pola-R-CHP and compare this therapy to pola-R-CHP alone. This is an ongoing study with over 1,100 patients planned to accrue to this study. And we're really looking forward to the results of this study because it's building already on the improvements which we have seen with pola-R-CHP by adding bispecific antibody. What's interesting about the study that glofitamab starts at cycle 2, and the idea here is that the bulking of the tumor of the first cycle of chemotherapy can reduce the risk of cytokine release syndrome, and therefore make this regimen something which can be used safely in the community. And initial results of the phase 1b study and this study show that indeed this looks very feasible. So we're really eagerly looking forward to the results of this study. We are at the point where we see multiple positive studies in this space in the frontline setting. And that's a good problem to have. I love this problem. I think if some of those studies read out positive, we'll have to choose. And the question is always how we'll choose the regimen in the frontline setting, which is preferred. One clear indication would be overall survival. So if there's an overall survival advantage, those regimens clearly will be taken forward. The other thing is the degree of PFS advantage. With pola-Rx, we had seen some PFS advantage, 27% relative risk reduction, and the risk of progression and death. So, sustained progression-free survival differences like this and reduction in need of subsequent therapies and patients with primary refractory disease will be something which we'll be looking at, including this early separation of progression-free survival curves. As the response rates are getting higher and higher, we are just learning how to include MRD in assessment of those patients. So, high level of MRD negativity, which could be in the long term associated with better progression-free survival, can be used as a guide as well in this setting. Finally, since diffuse large B-cell lymphoma is molecular heterogeneous, I think with multiple positive studies, we'll be looking more and more on a different subset analysis and try to identify the patients who can benefit the most from addition of those novel agents. And there's always an issue of complexity and cost logistics as well, which will play. But I think we're at this dawn of the new era where we'll have multiple therapies to choose from in a frontline setting. It's already the case in the relapsed refractory setting. And this is really very exciting to our patients and to everybody in the field that the outcomes of the patients will continue to improve. I hope you find those modules useful, and thank you for your attention. Goodbye.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Genentech, a member of the Roche Group. To access all materials for this activity, visit peerview.com/VFP860.